So first I wanted to thank Lenny for the invitation to speak to this very distinguished audience. This is a great opportunity and very timely because at UCSF, via the leadership of our pediatric colleagues, Minyon Lo, we've been talking about how to implement an AYA program, and so some of the concepts that have been discussed here are actually very timely. So I'm a member of the adult BMT faculty at UCSF. I have never taken care of a child patient, and so I come from a slightly different perspective. And I also want to say I have no financial affiliation with Sequenta. I'm going to be talking in a little bit more narrow terms about the clinical utility of MRD quantification in transplant, and we'll discuss a collaboration that we did with Sequenta and then some of my experience using their clinical product. And so if we look at the outcomes of allogeneic transplant for ALL via these data from the CABMTR, we can see that good outcomes, if we can call them that, are only occurring for patients that are transplanted early in the disease course. And by CABMTR criteria, this means transplant in CR1. The intermediate stage is CR2 and beyond, and the advanced stage is chemotherapy refractory disease. And the outcomes don't matter so much whether you get a sibling or unrelated donor. And the outcomes are actually fairly similar between those under 20 and those over 20, but if you segregate it further to those over the age of 40, you start to see some diminishment in overall survival. Now, the most common way for patients to fail after transplant is actually recurrence of the primary disease for which they were transplanted. And that's true whether you get a sibling or an unrelated donor. These data, again, from the CABMTR are for all malignancies for which patients receive transplant, and this is also true for ALL. And in ALL, the ability to salvage a patient after a post-transplant relapse is quite dismal. These are data that were reported from the MD Anderson, where they looked at about 120 patients over nearly 2-decade experience with patients undergoing myeloablative allogeneic transplantation for ALL and experienced a relapse. And they tried to salvage these patients in a number of different ways, including intensive chemotherapy, so-called mild chemotherapy, which is usually a monotherapy with a nucleoside analog or other new novel agents at the time, a second transplant, donor lymphocyte infusion, DLI, with or without antecedent chemotherapy, or radiation. And you can see that whether the patients relapse prior to 6 months post-transplant, the blue line, or if they relapse more than 6 months after transplant, the red line, survivorship is really quite dismal, with less than 10% of patients surviving with any of these modalities of salvage. And so, unfortunately, transplant is the end of the road for patients with ALL, and if they fail that, they're likely going to die from their disease. A similar study from the EBMT with a slightly larger patient sample size, about 450 patients, showed a similar outcome. Again, less than 10% overall survival for ALL relapsed after allografts at 5 years. And so those of you who don't transplant might say, well, there have been a number of improvements in transplantation. We have better conditioning regimens, we have better supportive care, better antifungal drugs. Hasn't there also been some improvement in relapse rates? And unfortunately, there have been no improvements in relapse rates for ALL. This is a very nice study from Bill Wood on behalf of the CIBMTR, where they looked at the outcomes of transplant for ALL in children, and they had nearly 100 patients. The AYA population, defined as age 15 to 40, had about 1,200 patients, and then older adults. And there's always jokes about what's an older adult, and this is really starting to infringe on me because I'm savoring my last year as an AYA. And what this study showed was that although there have been some improvements in overall survival in children and to some extent AYAs, there's been no improvement in overall survival for older adults. But more importantly, for all of these groups, there's been no improvement in relapse rates for the primary disease ALL for which these patients were transplanted. And that's true in children, that's true in AYAs, and that's true in adults. And if anything, the relapse rates have actually gone up due to differences in patient selection and higher risk patients actually coming to transplant. Another interesting facet of the study shown on the lower right is the outcome of patients in the AYA population age 15 to 25 in a recent era of therapy, 2002 to 2007, whether they were transplanted at an adult center or a pediatric center. And you can see the outcomes are the same. So although pediatric hematologists are better at primary induction therapy and maintenance therapy and have better outcomes, they're not necessarily achieving better outcomes with transplant. The use of different conditioning regimens, different graft manipulation techniques is actually not leading to an improvement in relapse rates after transplant. And so I wanted to, rather than discuss a whole slew of studies, just pick a few that I think exemplify some of the pertinent details about MRD in the transplant setting. And I particularly favor this study from a group in Italy where they looked at MRD both prior to and then in serial fashion after allogeneic transplant. This is not a large study. There were 82 patients. These were all children in AYA under the age of 20. MRD was quantified by ASO-PCR, and these are mature data with median follow-up after transplant of nearly 5 years. The criteria for transplant were fairly typical in terms of high risk, being MRD positive at a high level, greater than 5 times 10 to the minus 4 at day 78 of initial therapy, an induction failure, high-risk molecular lesions known at the time, which were Philadelphia chromosome and MLL, and then in the T-ALLs, a white blood cell count greater than 100,000. Patients who came in a second or greater remission also were taken to transplant. And I'm not sure that you can see all these numbers, but I'll tell you they ended up with 82 evaluable patients. And what they did is if patients had less than 10 to the minus 4 disease at day 78, they proceeded to transplant as soon as their donor was available. If they had greater than 10 to the minus 4 disease, they underwent dose intensification. And I should mention this is all BFM-based therapy. They underwent dose intensification, and if they achieved less than 10 to the minus 4 disease, they had a similar outcome with 77% 5-year survival. So no matter how you get to less than 10 to the minus 4 disease prior to transplant, the outcomes are good. Now, in those who could not achieve less than 10 to the minus 4 disease at the time of transplant, their 5-year overall survival is less than half. It's around 31%. And so this is quite poignant. If you look at the relapse rates based on the pre-transplant MRD assessment shown here, those who had less than 10 to the minus 4 disease had a very, very low rate of relapse after allotransplantation. Those who had greater than 10 to the minus 4 disease had nearly a 60% rate of relapse. And what I think is very important about this study and potentially instructive to us in how we can employ MRD quantification in a serial fashion in the transplant world and potentially to a broader context is if you look at these data that they collected with serial MRD assessments at 1, 3, 6, 9, and 12 months after transplant, you'll see the longer that patients remain MRD negative, the lower and lower is their likelihood of ever relapsing, with just 3% relapsing if they were MRD positive 1 year after transplant. Now, on the other hand, those patients who were MRD positive, even at late time points like 9 months or 12 months after transplant, had a high rate of relapse. Now, these are certainly small numbers, but I think potentially instructive nonetheless. So just to say, this isn't the only study that's looked at pre- and post-transplant MRD. This is a nice study in the pediatric population that looked at 140 children who underwent myeloablative allogeneic transplantation. Again, in this study, MRD was quantified by ASO-PCR at the immunoglobulin T-cell receptor alleles. And those who were MRD negative at the time of transplant had cumulative survival of about 75%. Those who had low-level MRD positivity, which in this study was defined as less than 10 to minus 3, had significant decrement in their overall survival, and those that had more than 10 to the minus 3 disease at the time of transplant had very dismal survival at just 20%. If we look in the adult world, this is a study. The adult MRD studies are necessarily smaller because MRD has not penetrated into the thought process of adult practitioners as much as it has for pediatricians. This is a study of 43 patients who underwent, these are all adults, who underwent myeloablative conditioning in CR1 for ALL. MRD quantification was using ASO-PCR at the immunoglobulin TCR alleles or BCR-ABL or MLL rearrangement quantitative PCR. And if you look at overall survival based on pre-transplant MRD, it was around 80% for those who were negative and about 50% long-term or 25% long-term for those who were MRD positive. If you look at the cumulative incidence of relapse, this is a very familiar figure by now. Those who were MRD negative prior to transplant did not relapse, and those who were MRD positive had a high rate of relapse of nearly 50%. And then, interestingly, this study also looked at MRD positivity through day 100 after transplant. And if you look at the cumulative incidence of relapse, if patients remain MRD negative during that first 3 months, which we consider to be critical for engraftment of the donor, there's a low incidence of relapse. However, if they have any MRD during that period of time, nearly all of those patients will relapse. And so you might wonder, with data that are robust as these and other studies, why hasn't MRD penetrated into the standard of care management for AYAs and adult patients? And I think it's because whereas in the pediatric world, MRD initiated on these very well-organized clinical trials and an apparatus was set up for flow-based MRD via those mechanisms, that has not been the case for adult practitioners. And as we've already learned, the management of adult ALL is much more disseminated, with even community programs feeling very comfortable, for better or worse, inducing patients with ALL and thus losing the opportunity to capture relevant samples for MRD assessment. But if we look at the available technologies, first with flow cytometry, that conventionally has a sensitivity of 10 to the minus 4 or 1 in 10,000, but can reach sensitivity of 10 to the minus 5 with special changes to the way the process is done, including capturing more events and paying a technician more time to actually capture enough events to have that level of sensitivity. It can rival the sensitivity of molecular techniques. One might say that flow cytometry is widely available, but as Dr. Hunger said, all flow MRD is not equal. Community programs may do flow cytometry, but they may not certainly interpret it like Mike Borowitz or Brent Wood. There are some additional constraints on flow cytometry, including that it's really best done with fresh material, and the results may not be as reliable if the sample has been frozen. Now, if we look at ASO-PCR, which has been very successful in Europe via the Euro MRD consortium and has a sensitivity down to 10 to the minus 5 with good routine, there are some limitations for implementing this, including the fact that you have to design a patient-specific primer and probe set for that quantitative PCR for each patient. And you have to have staff in place to do that. You have to have an infrastructure for this to be done at each institution or in some centralized manner. And that hasn't really been feasible here in the United States. And most likely, patient-specific tests would probably not pass muster as a companion diagnostic with the FDA. And so this probably, even though it's been successful in Europe, is a non-starter in the United States. So enter next-gen sequencing, which has deep sensitivity, as Dr. Faham has explained, of 10 to the minus 6, and has the added benefits that there's no customization necessary. These are off-the-shelf reagents that the companies that do this have generated, and there are additional benefits that fresh or frozen material are available. This is relevant for when a sample can be sent for MRD. Those of us who have Friday afternoon clinic realize there are constraints on what we can send. I can't send flow cytometry-based MRD on a Friday afternoon. I can, however, get a sample and have it sent on Monday to Sequenta for MRD analysis. And so that liberates me as the practitioner to take care of my patients 5 days a week during the entire day the way I want to. There's some additional benefits that we've looked into, but I won't talk about, and that's actually interrogating the entire repertoire info to look at things like immune reconstitution. Now, there are certainly some drawbacks that one could draw between these other methodologies and next-gen sequencing. One, quite frankly, is turnaround time. I think that Sequenta has done a nice job of enabling a 7-day turnaround time, but it's not the 24-hour turnaround time that you get with flow cytometry if you send it to Brentwood's or Mike Borowitz's lab. And then, of course, there's expense related to all of these, and how can our medical system bear the expense of yet another new molecular diagnostic? I would say we're appropriating a lot of resources by getting labs that we don't make decisions on, and if we choose wisely, as the campaign admonishes us to do, we could use those resources to get tests that we will make decisions on. And so, as Dr. Faham explained, with the Sequenta methodology, they obtain a diagnostic sample and through consensus PCR of multiple receptor alleles determine which will be informative for that malignancy. And then after you know the sequence of that clone or clones, it's really kind of a bioinformatic endeavor at that point to simply count in successive samples what the quantity of that clone is. And there are algorithms to turn that into an absolute quantification. As Malik explained, we previously looked at this technology in CLL in the post-transplant setting and showed that at a 1-year landmark analysis, you could segregate patients who likely were never going to relapse from those who were fated to relapse based on whether they had as low as 10 to the minus 6 disease. And importantly, if you look at serial samples, and detect MRD doubling, based on the disease burden at that time, you can predict with pretty good certainty whether they will relapse within 12 months or 24 months. And so we applied this study when I was a fellow at Stanford to a retrospective cohort of samples from 29 patients with B-ALL. These were all, or mostly, high-risk patients. More than a third had BCR-ABL translocations, and only 40% were transplanted in first remission. The other 60% were transplanted in CR2 or beyond, and a substantial portion had relapsed refractory disease. Most of these patients had undergone ablative transplants with peripheral blood stem cell grafts. So if you look at the outcome of the initial diagnostic sample assessment via the ClonoSIGHT methodology, you'll see that the diagnostic samples had very high levels of whatever immunoreceptor clones were associated with the ALL of that patient. And interestingly, although this is a cohort of strictly B-ALLs, there's a substantial portion that have TCR rearrangements, and this is already well known from prior literature that pre-B-ALL can have rearrangements at any of these TCR loci. Now, of this 29 patients, we were able to identify a trackable clonotype in 92%, and more than half of the patients actually had 2 or more clones that were suitable for tracking for MRD. In the study, we assessed about 240 samples, of which we had around 40 paired peripheral blood and bone marrow samples, and so we wanted to address the question of relative sensitivity in these 2 different compartments. And you'll see here peripheral blood and bone marrow with the disease burden demonstrated here. You'll see that generally there is more ALL in the bone marrow than there is in the peripheral blood. And in fact, there are cases where the peripheral blood is negative, but it's usually confined to when the bone marrow disease burden is in the 10 to the minus 5 to 10 to the minus 6 range. So it's important to know this because the bone marrow is, in this study, on average, about a log more sensitive than the peripheral blood. But the deep sensitivity of the assay with 10 to the minus 6 being the lower limit of detection allows us to detect low levels of peripheral blood and perhaps decrease the frequency with which we're sampling the bone marrow and only doing bone marrows when we see something in the peripheral blood. Now, if we look at outcomes based on pre- and post-transplant MRD status, those who had MRD greater than 10 to the minus 4 within 30 days prior to the initiation of their conditioning regimen had uniform relapse, and they all unfortunately died from their disease. Those who had less than 10 to the minus 4 disease still had a pretty significant rate of relapse, perhaps because this was a high-risk cohort. And what I will say is there just simply weren't enough samples in this pre-transplant assessment that had disease burdens between 10 to the minus 4 and 10 to the minus 6 for us to say anything about that threshold of detection in this particular study. On the other hand, if we look at samples through day 100, analogous to the study that I previously showed you that used other quantitative PCR techniques, if there was greater than 10 to the minus 6 disease detected during that critical first 3 months, all of those patients relapsed. And if they remained negative during that period of time, they had roughly 60% disease-free survival. We did have serial samples for many of these patients, and those who remained persistently MRD negative did not relapse. The 2 steps in the survival curve here are from patients that died of complications of graft versus host disease. And those who were never MRD negative or had a transient MRD negativity had very poor outcomes, and they all relapsed, and almost all of them, unfortunately, passed from their disease. So if we look at the time from molecular progression when we had serial samples to the time of clinical relapse, we can learn that there is an important window that's enabled from serial sampling. And that window is a potential time for us to intervene on minimal residual disease and potentially prevent an overt clinical relapse. In this particular study, that window is around 3 to 6 months. I think that a different prospective study might give more robust data because this was a tissue bank-based study, so it was catch as catch can. The samples were not all coordinated at the same exact time points. But nonetheless, there is almost certainly a window where you can detect MRD progression prior to clinical relapse. Now, what would we even think about doing in somebody who's progressing after an allogeneic transplant? I think we have a lot of options. We can suppress taper their immune suppression if they're still on it. We can consider donor lymphocyte infusions with or without augmentation with chemotherapy or cytokines. We could just use conventional chemotherapy, and I would include in that consideration for asparaginase. We might use hypomethylating agents to increase expression of alloantigens. That might have some stimulatory effect for GVL. We can use targeted agents for relevant molecular lesions, TKIs, JAK2 inhibitors for the pH-like and so forth. There's antibodies that we can consider using that are readily available, rituximab, ofatumumab, inotuzumab. Eventually, when blinatumomab gets its approval, many of us are excited about the potential of using this post-transplant. There's also a similar to the bispecific T-cell engager. There's a bispecific killer cell engager that's being developed at University of Minnesota with Jeff Miller's group. You could consider using an immunomodulatory agent such as lenalidomide or a retargeted cell population such as CAR T cells. Certainly none of these decisions would be easy, but there are things that I think we can think about even today doing for these patients who are progressing with MRD after transplant. So some brief conclusions here. We've demonstrated that ALL relapse is actually very common after allogeneic transplant, with about a third of patients relapsing. And relapse after transplant is associated with near uniform lethality. And so this is something that we need to improve our management and trying to avoid. MRD quantification prior to transplant predicts the risk of post-transplant relapse. And intensification therapy to achieve less than 10 to the minus 4 disease prior to initiation of conditioning is very likely to be associated with improved transplant efficacy. And I think that's a very important point. We've shown that the ClonoSIGHT methodology from Sequenta does provide 10 to the minus 6 sensitivity, and that appears to predict relapse even when there are low burdens of disease present after the transplant. And then, as I mentioned, we need to develop some methods for averting clinical relapse when we see relapse in evolution. And so I wanted to end with 2 cases from my own cohort of patients that I've been using the Sequenta clinical product, because I think that they are enlightening and can show us how this readily available technology can change how we think about MRD, how we think about quantifying multiple clones within the disease and tracking it sequentially over time. So one example is a patient who was 51, had relapsed TALL, and he had initially been diagnosed and treated at a community hospital. Had actually relapsed at the community hospital and already received and failed salvage regimen when he came to us. With some difficulty, we were able to achieve a second remission and then took him to a transplant. And so this figure that I'm showing is the data that I download from Sequenta's clinical portal, where they will graph the patient's data and make it available to download and put into your electronic medical record. And what they'll show is the disease burden in whatever diagnostic sample you send them or you ask them to obtain, for instance, for this patient when they were diagnosed elsewhere. And then if we send blood samples or bone marrow samples, they'll graph that out in terms of disease burden shown as number of leukemia molecules per million leukocyte genomes. And to fill in some of the clinical data, when this patient relapsed, he had a substantial disease burden. As I mentioned, we were able to achieve a second remission, and at the time that we did his remission bone marrow, we had not yet gotten this sample to Sequenta, so we were not able to assay that, but I soon thereafter assayed his peripheral blood, and he had basically 10 copies per million in his peripheral blood. We had to deal with a donor delay, so I gave him some high-dose methotrexate, and then his pre-transplant bone marrow by ClonoSIGHT showed 3.5% disease. So I knew he was very, very high risk going into this. Unfortunately, had a relatively borderline functional status, so he was not a candidate for a TBI-based transplant, so we gave him a RIC regimen with fludarabine and melphalan and gave him a 10 out of 10 MOD. Roughly a month after transplant, he had circulating disease at a low level of 10 to the minus 4 in his peripheral blood. Just 2 weeks later, it was on the rise, and by the time we checked his bone marrow, he had already relapsed. None of this was really unexpected for this patient. He had very vicious TALL, and I don't think there was likely anything we could have done with available agents to save him. But what's very interesting about this case is if you look at the clones that were detected by ClonoSIGHT at the time of his relapse, and then when he relapsed after transplant, you'll see that they're different. And so when he relapsed here with roughly 40% disease burden, almost all of those were a TCR delta clone. There was a subclone that carried a TCR gamma rearrangement. And you'll see that after our achievement of CR2, the TCR delta clone has been debulked by more than 2 logs, but the TCR gamma clone really hasn't changed. And this is the clone that ultimately leads to his rapid relapse after transplant. So this is some aspect of disease biology that's being unveiled by this multi-receptor sequencing platform that you can't get from flow cytometry, you can't get from ASO-PCR. This definitely needs further exploration because maybe we need to achieve a certain debulking for all clones that are present in the disease in order to have good outcomes from transplant. So that's just food for thought about how this can grow into something more. And then the last case that I wanted to show is this 37-year-old gentleman who had a CD20 positive BALL, had been treated at a community hospital. After his remission, he had 0.4% MRD by multi-parameter flow at day 30, came to us in a CR1, and based on these high-risk features, the 0.4% MRD, and I know it's controversial, but the CD20 positivity, we decided to take him to an allograft. And so his clinical course is shown here. He did have a TBI-based allograft with a 10 out of 10 matched unrelated donor. I'll mention that his donor was ABO major mismatched. After his transplant at day 90, I had not yet gotten this sample to Sequenta, so I sent multi-parameter flow to the University of Washington, and he had 0.03% disease in his bone marrow. He also had pure red cell aplasia, and so to deal with this, I tapered his tacrolimus, and I told his insurance company that I was using rituximab to treat the pure red cell aplasia, but his MRD was CD20 positive, so it was as much for the MRD as for the pure red cell aplasia. By 3 months after that, I did have the ClonoSIGHT assay set up with Sequenta, and to be fair, I sent it to both Seattle and to Sequenta. We had 0% disease by multi-parameter flow, and we had 0% disease by ClonoSIGHT. Around 11 months post-transplant, he developed isolated neutropenia. I thought for sure this was going to be the harbinger of relapse. It just so happened that he had a parainfluenza 3 infection that likely caused his neutropenia, and that bone marrow was completely free of disease. ClonoSIGHT gave us a number of 0 on a good bone marrow sample. So a couple of months later, I checked his peripheral blood and was surprised to find that he had a low level of disease burden in his blood, 1.5 copies per million. And so as a good scientist, I sent another sample and got the exact same result and said, uh-oh, we may have a problem here. So I did recently, and this is all happening in real time, I did recently send a bone marrow, and I sent it to Seattle. It was negative by flow, and there are 3.3 copies per million of his disease clone present in his bone marrow. He's 14 months post-transplant. I don't know what this means. I don't know that this definitely is a harbinger of relapse, but I think there's a high likelihood that it is. In order for a patient to get to a high level of disease burden, they necessarily need to pass through a low level of disease burden. And so the easy availability of the ClonoSIGHT test allows me to not wonder, but to just measure. And so I can follow this over time and see which direction this is going. And so I want to finish with this figure that exhibits what I think MRD is really all about. At any point in time, whatever disease burden you quantify is the sum of forces that are going in different directions at that time for that patient on their disease. So the disease is suppressed from clinical relapse down to low levels of disease based on their initial response to therapy, their maintenance therapy, and if they have an allogeneic transplant, the graft versus leukemia effect, which we extrinsically suppress by using immune suppression, and we have some control over that. Of course, the likelihood to relapse and increase the disease burden is driven by bad genes, all the molecular lesions that we've talked about here, and then mechanisms of immune evasion. For these patients who, if they relapse, they're almost certainly going to die, we have very little control over most of this process, particularly in the adult world where many of our patients are treated in the community. We don't get to select their primary therapy. We don't need to make sure that they have appropriately intensive therapy. They come to us based on whatever pathway they've taken. And so the only things that we really have control over in the transplant world is how we manage their graft versus leukemia effect, how we manage their graft versus host disease, and then potentially if we marry information about the molecular lesions that are present in the disease with their disease burden and employ appropriate targeted agents at an early time before they have a clinical relapse, maybe we can actually avert clinical relapse. Maybe we can enhance the graft versus leukemia effect. We certainly need to have studies that can validate this, but right now these are real decisions for real people that we can and need to make with these technologies so that we can achieve better outcomes. So with that, I wanted to thank the co-authors from Stanford and Sequenta who participated in the collaborative ALL study that I mentioned. And then lastly, I wanted to admonish Dr. Sender because this is a conference about AYA and we haven't seen any hashtags. So there is a hashtag for the conference. There's actually a few of us in the audience who have been tweeting a little bit. And after that, I just want to thank you for your attention. So thank you.